Hello everyone. Today we will discuss about the metabolic pathway, that means the digestion and the absorption of the glucose in our GIT. Now first of all, digestion of glucose. Now as you can see over here, in the human being body at various places the glucose is actually digested. Means that is, it is in the GIT actually the polysaccharide. Whatever we eat in our diet, they are mainly two. Either polysaccharide or either disaccharide. They are mostly not monosaccharide. They may be monosaccharide, but the monosaccharide amount is less, while the disaccharide and the polysaccharide unit in them are more. So it should be digested to the monosaccharide, because body in our body only monosaccharide units are absorbed by our body, right, in the blood. So first of all, the digestion actually begins in the mouth by the salivary amylase or salivary alpha amylase. The starch mainly, just remember, salivary amylase actually only digest the starch, okay, and it will convert the starch into mainly two, dextrine and maltose and isomaltose. Just remember that the series of digestion is, first of all, the starch is a polysaccharide, right? Then it will convert it into dextrine. Dextrine is also a type of polysaccharide only. Then dextrine is converted into mainly oligosaccharide. Then the oligosaccharide will convert into maltose and then isomaltose and then glucose. So these whole series actually goes in our body to convert finally the polysaccharide, that means the starch, into a monosaccharide, which our body can absorb. So just remember that our salivary amylase or whatever the digestion occurs in the mouth is only of the starch, and the starch is converted into one dextrine, means the dextrine, and the maltose and isomaltose, not the monosaccharides. These two are the disaccharides. Okay, now next the food will actually go into our GIT further. Now just remember that the in the mouth minimum or very less amount of digestion actually occurs, because the food doesn't stay more in our mouth, and secondly, whatever salivary amylase actually acts on it or sticks into it, it will go further into our further GIT, and it will actually reach in our stomach. In our stomach there are HCl. So this HCl will actually inhibit the functioning of the salivary amylase, and so the salivary amylase cannot further act on the food to digest, as because HCl inhibits its function. Next is the pancreatic amylase, which is secreted by the pancreas in our body. Right? It will digest mainly two things. Remember, starch and glycogen. It will digest only two things, starch and glycogen, and will convert these two things into mainly dextrine, isomaltose, maltose, and oligosaccharides, branched or unbranched. Okay. Now, this pancreatic amylase acts mainly on the alpha-1,4 glycosidic linkage of the polysaccharides. Okay, mainly acts on it randomly. Now next are the intestinal brush border cells. Now mainly the main digestion of the food or the polysaccharide actually occurs in the intestine only. Main digestion and absorption occurs in the intestine only, and by the intestinal brush border cells. Now I told you before in my disaccharide video that there are mainly 4 disaccharides, that is sucrose, lactose, maltose, and isomaltose. So respective their enzymes are present in the intestinal brush border cells. That is the respective name enzymes, that is the sucrase, lactase, maltase, and isomaltase, right? And they will digest the particular name substance. Sucrase will digest the sucrose and further more, right? So intestinal brush border cell actually digests rest all polysaccharides and disaccharides. Trihalose, maltase, isomaltose, this all are actually digested by the intestinal brush border cells. And just remember the series of digestion. First of all, polysaccharide, that means the starch, further digested to the dextrine, then oligosaccharide, then maltose and isomaltose, and further into the glucose. Now what if we take directly monosaccharides only? What if we take directly monosaccharides? Just remember, monosaccharides are not digested by our body, because it is easily available for absorption purpose, right? So it is mainly available as product as sucrose and pentose. And what about the fibers? They are also not digested for bulk of stools and bowel movements and fermented by the intestinal bacteria. So starch by salivary amylase, glycogen by pancreatic amylase, starch by pancreatic amylase also, and rest all disaccharides by the intestinal brush border cells. Now very important clinical aspect of this is the lactose intolerance. You might have heard about this. Now what happens is, I told you before that the intestinal brush border cells, means the enterocytes, actually have the lactase enzyme which will actually digest the lactose, right, the disaccharide lactose. But in some human being, this particular enzyme lactase is not present in the body or in the intestinal brush border cell or the enterocytes. So actually this lactose actually accumulates in the human being's GIT and actually causes various other problems like abdominal cramping, bloating, gas, nausea, diarrhea, and occasional vomiting. Okay, so all these symptoms are actually of the lactose intolerance. Now this lactose intolerance are mainly of 2 to 3 types we can consider. First of all, it is the primary lactose intolerance. In this, the human being is actually at the time of the birth, he was having particular lactase enzyme in the body, but as he grows up, the amount of lactase enzyme in the body decreases. So they are known as the primary lactose intolerance. A steady decrease in the lactase enzyme causing individual outside of the infancy to be unable to properly break down of dairy products. And the secondary lactose intolerance, that means occurs after any kind of injury or illness or surgery. Okay, means this primary is mainly because of the decreasing amount of the lactase enzyme, while this is because of any kind of injury or surgery. Congenital, of course, by birth only the baby or the infant is not having lactase enzyme. So the adults can ignore the lactose containing product like milk. They can avoid dairy products. But what about the kids? They're actually fed up by, they're actually given only milk at their birth time, right? So actually they are, the newborn are actually given products which are free of lactose in their diet instead of milk. Now, there is no particular treatment for this lactose intolerance, okay, but the human being can avoid any kind of dairy product too. Okay, now next is the absorption of the carbohydrate. Now we are done with the conversion of polysaccharide into monosaccharide, because monosaccharide is very important because our body only absorbs monosaccharides. Now out of the 3 main monosaccharides, galactose, glucose and fructose, galactose is the monosaccharide which is maximum absorbed by intestinal cells, while glucose is medium and fructose is minimum absorbed. Now first of all, let's talk about the absorption of the glucose. Now over here, first of all, to be get absorbed, over here as you can see, this is the intestinal lumen or the inside of the intestine. This is the intestinal epithelial cell or the brush border cells of the epithelial cell of the intestine, and this is the blood. So to be absorbed, the glucose or the monosaccharide had to be transferred from this into this and then into blood. So first of all, let's talk about the transportation or the co-transport of the glucose from the lumen of the intestine to the intestinal cells. Okay, so it is done by the co-transport mechanism. What is co-transport? In this, the glucose actually transported along with some other substances. Over here it is sodium. So over here, just remember, we have many of the glucose transporters from GLUT1 to GLUT7, and then sodium dependent glucose transporter also, okay, which actually transports this glucose from the lumen into the intestinal cell. Okay, so and then into this. Okay, so there are many glucose transporters, but over here for the entering of the glucose from the lumen into the cells, there is main one glucose transporter used, known as the sodium dependent glucose transporter 1. Just remember the name, sodium dependent glucose transporter 1. So it is present into the over here it will present, and it will co-transport glucose and sodium by the secondary active transportation, and it is carrier mediated process, so it will take energy also. So now these two will actually enter into the intestinal lumen by the sodium dependent glucose transporter 1. But in this actually occurs only in the intestine. What for the kidney? In the kidney, just remember, at the same position, sodium dependent glucose transporter 2, S-GLUT2 is used instead of S-GLUT1 in the kidney. So of course, if there is glucose galactose malabsorption occurs in a particular patient, so you can decide that the S-GLUT1 is faulty. There is some problem in the S-GLUT1 because there is glucose galactose malabsorption, right? But what if there is defective in the congenital renal glycosuria? So just we can take an assumption that S-GLUT2 is faulty or defective. Why? Because there is problem in the renal part. So congenital renal glycosuria is actually occur because of the S-GLUT2 defective, and S-GLUT1 is faulty in glucose galactose malabsorption because S-GLUT1 is present in the intestine while the S-GLUT2 is present in the kidney. Now mainly the clinical importance of the absorption of the carbohydrate is, now mainly in the diarrhea what happens? In the diarrhea the food is actually digested well, okay, but the absorption of the food is not done. So for this, whatever oral rehydration fluid we take, it mainly contains the sodium and the glucose. So presence of the glucose and the sodium in the oral rehydration actually allows the uptake of the sodium to replenish the body sodium chloride. So actually you get healed by the diarrhea because of the sodium and the glucose present in your oral rehydration fluid. Okay, now the release of the glucose into the blood. Till now what we did, we actually did the transport of the glucose by the cotransport mechanism from the lumen into the intestinal epithelial cells. Now by the Uniport system, we can see the facilitated Uniport system, what we will do, we will transport the intestinal the glucose from the intestinal epithelial cell into the bloodstream. Okay, now this process is Uniport and facilitated diffusion occurs in this process. And over here GLUT2, out of all these glucose transporters, only GLUT2 is used, glucose transporter 2 is used for this process. That means transferring of the glucose from the intestinal epithelial cell into the blood cell. Now what actually happens in this process is the ping pong mechanism occurs over here. That means whenever this glucose bind to this glucose binding site of the GLUT2, so what will happen, the glucose binding site of this transporter actually closes, and then the configuration change occurs in this transporter, and what will happen, this will cause opening of the outside binding side of the this glucose, and the glucose will come inside the blood from the intestinal epithelial cell. Just remember that the GLUT2 is present in mainly 4 places. That means the kidney, liver, intestinal cells, and also in the beta cell of the pancreas. Now what happens in the beta cell of the pancreas is that GLUT2 is present in the beta cell of the pancreas, and GLUT2 has a very high affinity for the glucose. GLUT2 has high Km value. What is Km value? Km value, that means the affinity value. If Km is high, affinity is high. Km is low, affinity is low. So GLUT2 has a high affinity for the glucose. So in the beta cells of the pancreas, if the amount of GLUT2 is more, so pancreas will secrete more amount of insulin in the blood to decrease the amount of glucose in the blood. Okay, so because of the GLUT2 only, the pancreas are able to sense the amount of glucose in the blood. So if more GLUT2, more glucose, so more amount of insulin will be secreted by the pancreas. So in short, we can say that this mechanism actually enables the pancreas to monitor the glucose level and adjust the rate of insulin secretion. Next is the GLUT4. What is GLUT4? GLUT4 is the glucose transporter 4. Now this is also very important about glucose transporter. Now what happens is, it is mainly present in the 2 areas. That means the muscle cells, and next is the skeletal muscle, and the next is the adipose tissue. And GLUT4 is under the control of insulin, while rest of the glucose transporter are not under the control of insulin. Now what happens is, the insulin actually induces the GLUT4, okay, the intracellular GLUT4 to actually come out and present in the cell surface, so that the GLUT4 actually take the excess amount of the glucose from the bloodstream into the muscle. Okay, so this actually GLUT4 actually what it will do, it will take the blood glucose from the blood into the muscle and will reduce the amount of glucose in the blood, and this GLUT4 actually induced by the insulin, or we can say it is actually in control of the insulin. Now what happens, the clinical application of this glucose transporter 4 is, what happens is, in the diabetes mellitus 2, this GLUT4, glucose transporter 4 is reduced, leading to the insulin resistance in muscle and fat cells. Now in diabetes, entry of the glucose into the muscle is only half of the normal cells, because the GLUT4 is not present in the muscle membrane. So whatever amount of insulin actually released from the pancreas, this will not cause any kind of, means the muscle is now resistant to insulin because GLUT4 is not present. So there will be no action of glucose on the muscle cell, and so in diabetes mellitus 2, DM2, the GLUT4 is not present in the cell membrane, and that's why the blood glucose level increase into the blood. Now the absorption of the other monosaccharides. Now glucose and galactose are mainly absorbed by the same transporter, that means the sodium dependent glucose transporter, and this is, always remember, this is energy dependent process against the concentration gradient, and therefore absorption is almost complete from the intestine only. But the fructose is actually absorbed by the GLUT5 transporter, glucose transporter 5. Other monosaccharides are actually absorbed by the carrier mediated facilitated transportation, and if absorption is not complete, the remaining molecule are fermented by the intestinal bacteria. So this was all about the digestion and the absorption of the glucose or the carbohydrate in the GIT or the gastrointestinal tract of the human being body. Okay, we'll talk about the glycolysis pathway in our next video. Hope you understood well. Thank you so much.